So hello everyone, welcome to this session on critical medicines. My name is Richard Bergström. You can tell from accent and name that I'm from Sweden. But I live in Switzerland, so it's a bit confusing. But I spend most of my time in Brussels, so it's even more confusing. Anyhow, welcome to everyone here in the Valley. Also all of you attending online. Great that you're there. Be active in the chat. We'll be monitoring. Also, we will be keeping some kind of heat map, put in the likes and everything on comments that people post. Also, we have the Slido questions in a bit, So everyone, please participate in that. First, thank you to the organizers of this session. It's Viatris and Medicines for Europe. It's a very important topic. And a few words just of introduction. So I've been in pharma a long time. I've been a payer, I've been a regulator. I was involved with the COVID-19 response. I'm sure we'll come back to that, okay? We had issues with shortages of medicines before the pandemic. But of course, it was augmented, accentuated during the pandemic with the closure of air freight, We had people that stopped exports, We had shortage of many things. Now we have war in many parts of the world. Suez Canal, you can't go through that anymore, apparently. So lots of issues. So we've been taught a lesson that these thin supply chains that we have, which are very cost effective, we'll come back to this, I'm sure. The fact that, we pay not that much for many of our medicines in Europe. We have very cost effective systems, but, they're vulnerable. So this is something that would be a theme throughout this conversation. I have to remind myself not only to talk about the EU, I'm a bit of an EU nerd, like maybe some of us. But some of the solutions that we will be discussing are maybe best addressed nationally or even voluntarily by the industry itself, by the sector itself and the different operators. So let's keep that in mind, that we shouldn't put all the efforts on the guy I'm going to introduce in a second from DG HERA. There's actually alternative solutions, and we need to sort of divide this up a bit. It's going to be a bit maybe technical, but we have to not, see everything as there's one solution for everything. We have to divide up the issues. So I will try and do that throughout this session. So I'm very happy to have such an excellent panel, and I'll introduce you now in the order, not in the order you will. Actually it's in the order you will speak. Yes. So Anka Toma is Executive Director for the European Patient Forum, the authoritative voice of patients in Europe. Is that okay?
Democratic, legitimate,
yes.
member-driven.
Member-driven, of course, yeah. But still authoritative in terms of having something to say, and people listen to you, okay? Walter van Dyck, who is a full professor at the Viatris Business School, and he's been doing some research in this space. So I think this is in the spirit also of European Health Forum Gastein, of which I'm a board member. We always try and have a balance between patients and citizens, academia, private sector, and governments, agencies. So Walter, you will come after Anka. Then we have Gloria Gekere, who works for the Belgian government, special advisor to the minister, and were very active during the Belgian presidency, which is now has rolled over to the Hungarian presidency. But your insights will be very valuable here because you are representing a member state where you deal with these things sort of front line, okay? Then Tariq Dero is here from, as I said, my favorite agency, DG HERA, that I partly worked for indirectly on COVID-19 vaccines, but excellent to have you here. Background at ECDC for many years, so very well placed to talk about countermeasures and responses. And then last but not least, my friend Adrian from Medicines for Europe, who will almost get the final word today because we're going to go this round for the panel and then this round for final remarks. But then I reserve the right to be the actual final commentator, Adrian. You know me. So we're going to start off with having I now presented the panel. So we're going to put up this slide now, aren't we? The Slido poll, right? Opening poll. You will see the QR code there. And be quick, because I've learned that the faster you are, you can influence the rest of the crowd. It's called herd mentality, maybe, I don't know, or leadership. So, who should take the leading role in ensuring the supply of critical medicines across Europe? Again, we're not looking for finger pointing and looking backwards and saying, how did we end up with this situation? No, now we need to be solutions oriented, okay? So, who should take the leading role in ensuring the supply of critical medicines across Europe? So we had these, maybe this was slightly leading questions, I don't know, probably. Authorities, industry, national governments, EU, okay, interesting. All of the above, I would have clicked if I had the phone in front of me, but I don't want to influence people. And you on the online as well, all of you watching this, please take part. Yeah, okay, all of the above, thank you. Bit of nudging worked. No, okay. So again, we're going to come back to this, that, what's the right balance of policy measures here? Where do we address this and how do we address it, okay? So now I'm going to turn over to our panel. And of course, you need to start with the voice of the patients. And I would say broader than that, Anka, right? I mean, this is about consumers, it's about citizens in general, right? So that's kind of a broad mandate, but because you represent the people that suffer from this, that show up to the doctor and they say, oh, sorry, we don't have this medicine anymore, so we have to take something else. Or you go to the pharmacy and they say, oh, sorry, we're out of this, and you have to come back another day or something. Anka, your perspectives on this?
Well, I'm very happy that you tweaked the question after our last conversation in the sense that it was, as you remember, framed, whose fault is it?
Yep.
And I think we need to get past the fault and we need to talk about responsibility. And my answer to this, and I answered, 36% who was in favor of all of the above. It is the role of every actor in the supply chain to ensure the supply of critical medicines, to ensure the supply of all medicines, actually. However, it doesn't mean everyone's responsibility has to mean a shared responsibility for every single actor. That is very well defined, and it has some clear accountability mechanism. Because the risk that we have now is that, okay, we say it's everyone's responsibility, so nobody takes responsibility. And then there goes the finger pointing, and then medicines are missing from pharmacies, and then we don't get anywhere. So absolutely all of the above. So if you answered anything else, you are wrong. There you go. It is the responsibility of everyone, but the EU can take a role in, and I'm looking at Tarek, in creating these accountability mechanisms and holding everyone to account for their commitments as part of the supply chain. And I think that is a role that should be played at European Union level because of the internal market that we're all part of and benefit from.
Excellent. No, well put, well framed. Again, no finger pointing. That's not very productive. Now, Walter, you've been doing some work as a professor and looking at this also from a competition perspective. And I know you have some interesting references to other parts of the world where people have worked with economic models. Because after all, it's all about an interplay between the private and the public, isn't it? It's a regulated market. Medicines are largely, at least in Europe, paid through mutual pockets. So this can't be solved alone by either party, right? So Walter, what are your observations and what work have you done?
There, Richard, I also think that it's a joint responsibility. So it's. But you could say that's a typical European problem due to our history. So it is a system problem, I would say. So that the whole thing about medicine shortages is really a system problem in the sense that become visible through supply chain issues. But in the end, it's not just about supply chain issues. Supply chain issues is just a result, I would say. What is the real problem is the price that you get for these medicines. And the prices that we get for medicines is, thankfully, a negotiated process. As you know, in branded, like in the US, this is not possible, but in Europe, we do this, and I think that's a good point. However, the European thing about this is that every country does this on its own, due to our history. That's how we are. So they command a certain price, and of course, because you want to have a sustainable, let's say, supply, you command or you ask also for stock levels. So you ask for, and if every country does this, then you get to chaos, basically. So you don't have any, Now, okay, so how can we get out of this? Well, I don't think a dictator-like approach is going to work. Hopefully, thankfully so, I would say. That there's like one big brother who is overseeing these prices. Probably we need a mechanism that countries can chime into if they think it helps their cause. And their cause is basically to have a working supply chain. And there, as you mentioned, so I'm an econometric modeler, so I like to think in terms of economic models that drive our behavior. The Canadians, they have a system, and it's called a tiered pricing system. It's not reference pricing, it's tiered pricing. So this tiered pricing, we can maybe come back to it later or something, but I mean, essentially what you do is you state, to the companies that are bidding for having a certain market to come up with a price. And here I come to a first touchy point. You command the companies to be transparent about the price that they charge. And this price is a percentage, let's say, of the branded medicine that they are going to replace. What is essential about the whole system is that it prevents what we economists call market failure. So market failure, which basically means that as a supplier, if you don't get a sufficient remuneration for your medicine, then you will, after a while, leave the market, because that is good practice as a manager, let's say. So that's why, and you can prevent this using this system. Now, of course, this is for Canada, and although they have provinces, which could be a bit like Europe, I would say, probably Europe is a little bit more complicated. So I think what I want to study in here, or what I'm doing for the moment, is to build up a simulation model, because of course simulation is a good method, because I mean you cannot just change the system, so you need to see what might be the outcome of it. So a simulation model where we see what kind of, what tiers do you need in order to have a system where prices are within the range of the feasible, and where welfare is also done, and where you have not so many shortages in your supply chain.
So you made the reference to the word tiered pricing means different things to different people. So in Geneva, global access to medicines context, people talk about tiered pricing as having different prices in different countries, and we even had that discussion in Europe, very much driven actually by the Belgian government at that time, that we needed to have differential pricing or tiered pricing within Europe for solidarity. Okay, so this is not what you're talking about, But it's interesting that we have examples in Europe also, don't we, where governments have intervened. There was an exercise, was it 10 years ago or something, when the French government stepped in and said, here are like 80 medicines that obviously are too cheap, and we need to increase the prices. And we had recently the example of Sweden, the country I know best, that stepped in and provided a revenue guarantee specifically for antibiotics. So there is some precedence here. But what do you think, Walter, is when you're talking about this in your circles, what is the appetite for? Because it's kind of interventionist, isn't it? It goes a bit against our sort of free market thinking, and it sounds like a state plan economy, or?
No, not really. It's a bit like Adam Smith would say, like the invisible hand that that you rise here, and the invisible hand is given by this pricing system that is being applied in a decentralized way. So that is being applied by the various countries, and they should, make a plea to abide to this system. And I would say the punishment, if they don't, is basically that they will have a disrupted supply chain. That's essentially how I would.
No, so it's
see
a
it.
mix of sticks and carrots.
Yeah,
that's
it's
required,
it's
right?
a sticks and carrot system.
No, we're going to get back to that, and that's going to be you,
Yeah.
not directly, Gloria,
Yeah.
but next step, we're going to ask you about that, because you've been involved with, the Critical Medicines Alliance and the sticks and the carrots, okay? Now, but before we get to that, I want to ask you, Anka. So we have this notion now of critical medicines. There's this alliance. There is a mandate now to the incoming health commissioner in the mission letters. I'm a nerd, so I've read them all, of course, to come up with the Critical Medicines Act. But aren't all medicines critical, Anka?
Of course, all medicines are critical, but they can't all be on a list.
No.
And I think this is, of course, all medicines are critical, otherwise they wouldn't exist. They are there to solve a real patient need, a real patient problem. However, and this is where the consultation with patient organizations comes in, we understand as a community that some needs are more stringent than others, and we are capable within our communities to do our homework, do our own alignment, do our own consultation, and bring some ideas and solutions and proposals to the table. They're not going to be the only proposals, but we have the capacity to bring balanced and representative ideas and solutions to the table about what should make, a first priority, second priority, that sort of tiered, different kind of tiers list.
Yeah. And of course, objectively, even if you can switch someone from one asthma drug to another,
I know you can't just do that. Though.
No, I mean, sometimes you can, but it's a lot of work, it's a lot of pain, it's a lot of confusion for people, So I think to that point, I think that all medicines are critical, aren't they?
Yeah, and having to switch in crisis situations it's very disruptive to patient care. It can be a threat to patient safety. It can be a threat to adherence. So it has to be managed very carefully. And again, this is where patient organizations can come in with the resources, with the community that they serve to inform, to involve, and to manage communications both ways about the shortages and their impact on patients.
Right.
But that's because shortages are an element of crisis for patients.
Yeah. So even if all medicines are critical for each patient, it doesn't mean you have to have policy interventions on all of them, right? That's your point. That's a list.
Well, it's
that could be
probably
shorter.
not very efficient. I mean, the whole point of the Critical Medicines Alliance is to prioritize, and we as organizations prioritize as well. Patients as individuals prioritize as well. I mean, we understand what prioritization means. Yeah. So it's important to really accept, and I have to say we are involved in the Critical Medicines Alliance, and that is a reflection of the fact that as a community, patient organizations are sophisticated enough to be able to contribute to these discussions in a way that is not hysterical, in a way that is thoughtful, that is evidence-based, that's based on the specific experience of patients. That is evidence as well. So that's why we can have a role in that.
No, but it sounds also that you feel that you're appropriately involved, which is excellent news.
Yes,
So I'll turn now to Gloria. You're sort of a founding woman of some of this work and the language, and you've been part of drafting texts and so on. So give us your perspectives on this, and particularly this reflection on what's critical and not critical. And then I will come back later to what should be done at Europe level and country level, but we'll keep that for later.
What's critical and what's not critical, right?
All medicines are critical.
No, I don't think so. I really don't think that all medicines are critical, honestly. Like, if you don't have your Sinutap or whatever, you won't die. There is a clear difference between medicines that severely impede your quality of life, and then the medicines that, or the medicines, if you don't have them, they will kill you. and the medicines that you just use to treat a cold. And I think we need to be very clear about this. So I don't think that all medicines are critical. But maybe if I may jump in on the price question, because of course it's one that goes straight to the responsibility of national governments, and I'm very well aware. And there, I agree in principle that some of the basic medicines that support our care systems are too cheaply priced. But then again, working with these medicine shortages as a member state, you also see that when companies make a commercial decision to withdraw from your market, price is not the only factor often. And I think this needs, we need to be honest about this. There have been many cases where a company decides to withdraw from our market, the Belgian market, and where we say, please stay, we really, we'll offer you a better price, whatever, and then, but your market is just not interesting enough. And this is something that you have when you're a small market, you have 3 languages, you're a bit annoying, sometimes you're just not interesting. And I think we need to be clear about this. I've also seen cases where the decision to withdraw from the market was due to a decision down the value chain where an API producer decided to start producing different APIs with the same production line. And that's why we want this Critical Medicines Alliance, and that's why we want this Critical Medicines Act, because you cannot solve the problem at the end of the value chain. You cannot solve it with price alone, even though we're really open to considering different pricing systems. I think we need to learn from the pandemic and need to learn that if we want to solve this problem, you need to work across the value chain.
Yeah. So I think one element that I know you have in your draft text is about solidarity. And I know some people are skeptical about countries sharing with each other, and we had examples where things get moved from one country to the other. Even though you shouldn't blame, I think, those distributors or wholesalers, because there's a country that says, I want this, and then you find it somewhere else and you ship it. But wasn't it so, maybe a leading question, biased question, during the pandemic we had some initial problems, okay, with protective equipment and so on, but then afterwards on vaccines and on antivirals and monoclonals and so on, that worked pretty well, didn't it? There was solidarity.
I think we've been through a process where countries have started to trust each other more and more on these issues. And it's also a process where everyone is hurt by this problem, and by helping each other out, sometimes you give and sometimes you receive. And I think countries understand this pretty well. Now, we are not always very open about what goes on with the solidarity mechanism, because it's a bit sensitive what you give and what you receive. Sometimes you're in the middle of a shortage, and as a government you see that you have some stock left that you could maybe help another country out with, but you won't put it in the press, But I can assure you that the solidarity system has functioned already. It has worked already. So countries have helped each other out. The only thing is, we need to continue to improve the system, because there's always legal questions that arise, logistical questions about payment. So there's improvement work to be done, but the willingness is certainly there, and it has worked.
Yeah, and maybe one learning for me at least is that sometimes it's good not to have the goods out there, but keep them centrally. We had the example, one of my, not favorites, but one example of what happened in the United Kingdom was that when there were suddenly some celebrities that talked about how great it was to take hormone replacement therapy, suddenly people started to take that, and people started trading with each other. Pharmacies were buying from each other, and there were, so behaviors that happened naturally can maybe be avoided for some medicines, not everything, but for some that are really critical, I would say really critical medicines, that you keep them maybe centrally. For the vaccines, we have a central warehouse, secret location. So you can ship them out to where it was needed, right? Which turns out then to DG HERA, the Health Emergency Preparedness and Response Authority, It's part of the Commission. And in the new Commission, you will have multiple reporting lines. Let's not get into that too much. The Kremlinology of Brussels we can leave out, but nevertheless, HERA, I think the authority came out of the COVID-19 response, and now you have quite a task, sort of reach of responsibilities. So, Tariq, great to have you here.
Yeah. Thanks, Richard. No, we do have quite a task, and looking at the result of the poll, I'm glad we did take action, and that work is ongoing at HERA level. I mean, recent months have been quite busy and progressing at a fast pace. I think I have to mention the Alliance and just introduce a bit the Alliance since it's been mentioned and it's quite present in various communications. So first, again, remind, and you said it, Richard, that the Belgian presidency was at the initiative of the Alliance and the starting point, and I think it's time to thank them again for this, for this. And also that, for such an alliance to operate, there's several elements we need. We need a strong political commitment, and I think we have. So we have now strong political commitment. This was, again, stated by President von der Leyen, her political guideline on the need to now move into reflection and discussion around the Critical Medicines Act, and also a strong call by member states after the communication on shortage back in end of 2023. So the alliance in a nutshell is, and also building on from the experience of COVID and also that you had with DG HERA, where HERA has established very strong collaboration with member states and with the private sector, with civil society when it came to COVID-19 vaccine and other medical countermeasure. I think HERA set up the alliance, which is really which is a collaborative forum involving member states. And when I say member states, it's not only one entity at member states. We're working with ministries of health, Ministry of Industry or Economics, or depending on how they are called according to various countries. Representative of paying authorities as well, payment authorities in some countries. Then, of course, working with the industry, to the association, and also through the companies directly, working with civil society as well, and also working very much in collaboration with other DG services and EU agencies. I mean, the topic of shortages is high on the political agenda. It's not only DG HERA dealing with it, it's also other commission services, DG Santé, European Medicines Agency, and so on. The position of HERA, or the work of HERA, is not looking at the immediate day-in, day-out solution or how to solve the issue for next winter. It's looking at mid to long-term solution, looking at industrial, really policy, industrial action. Starting with work that was done looking at supply chain. We've been mentioning vulnerabilities. Extremely difficult to understand where vulnerabilities lie, very much medicine dependent, country dependent, but you need to do that work. You need to have that understanding. We started based on the list of the 250 or so critical medicine issued by the EMA. And just to mention that this is a dynamic list, it will be reviewed. So it's not like something that was published and that will stay there as a published file. It will be reviewed. So we started from that list, identifying 11 molecules, 11 active ingredients, and really trying to understand where vulnerabilities lie. When I say vulnerabilities, it's really along the production chain. Trying to understand if we have to intervene with actions, with a political action, where should that be? Where should we provide investment in? At what stage of the production? Trying really to understand all these root causes of shortages. So this is the work that is ongoing now through the Alliance. I will not go now at this stage on the details of the work that is ongoing, but I can say that it's working at fast pace. We have a very clear and comprehensive working plan. We operate under the governance of a steering board with representative of the industry, member states, civil society who guide our work. And at the end of the day, at the end of this process of the Alliance, it will be up to the steering board to agree on the recommendation put forward. This recommendation will be the basis of the act. Okay? So this is a bit the situation just now, Tara.
No, very good.
I'll pause here for now.
Yeah, and I'm glad you mentioned manufacturing, because this is something I want to come back to in the sort of second round here. And advance warning to Yannis Natsis here, who represents the payers.
Yeah.
Now, if Walter says that the simple solution is to increase the prices, sorry, I'm exaggerating a bit to make it more fun, okay? So be ready for a curveball question later. Adrian, I mean, your members stand for at least 18, maybe 90% of the volume in Europe. Value less, that's the way it should be, isn't it? You know, you provide very cost-effective medicines, very cost-effective systems we have. The generic markets in Europe are very effective, and many of them are tender-like, and it's very difficult to have those people that operate those systems to think beyond the tender. Right, so I mean, your members are going through this every day, aren't you? You know, and they please comment on that, and also specifically, I think, you know, the cost of doing business, because this came up. You know, if you even leave a country like Belgium because it's too expensive, multiple package leaflets and languages and everything, right? So, Adrian, over to you.
Yeah, thanks, Richard. I think it's fantastic that Gastein is looking at this issue. It's obviously a little bit technical, a little bit industrial, but without secure medicine supply, a lot of the public health systems in Europe would not function, because these are the medicines that we're talking about. So you don't have anti-infectives, you don't have certain hospital medicines, you shut the hospitals down. So I think it's really, sometimes we forget about this kind of backbone of the healthcare system. I think we were reminded of it during COVID-19, because before we had the vaccines, well, we had the extreme stress on the hospitals, we had extreme stress on demand for hospital medicines, and that, I think, was really the wake-up call. And I appreciate that you brought up COVID, because I think COVID showed what the European Union can do together. Now, that doesn't mean that the Commission dictated everything, like the Soviet Union or something like that. Sometimes there was a lot of just coordination by the member states themselves, or the Commission acting as a kind of honest broker, but it really showed that Europe can do things together in the context of medicines. A lot of things that everyone said was impossible before. And I think this is really the challenge. So it was mentioned, I think, the price. I think if we take the critical medicines list, you have a lot of old generic medicines on there. Basically, in Europe, you have a capped price, which means the price is fixed at a maximum level. Then you have some kind of discounting or tendering or something like that. But I think the problem is that that capped price can very rarely increase. So if you have a medicine that's 30 years old, its price is also 30 years old. Okay, and this is the reality in Europe. And that means that for a lot of these products, you know, you're operating on very thin kind of margins. If you have additional costs, you remember FMD, you know, or the inflation crisis that we had in Europe, it has an impact on whether you can continue to produce those medicines cost effectively, or whether an API producer is going to continue or not. So I think this is where we are today. I mentioned antibiotics, but I'll mention also oncology generic drugs. These are extremely consolidated. You cannot believe how consolidated at marketing authorization level there are. And if you have consolidation, you have a risk of shortage. So think of it. Oncology medicines, 50% of the patients are using these in oncology, and these are the highest risk of shortage in Europe. So, you know, I'm not sure we've got really sometimes our priorities right. Now, the European Union can't do anything, but as Walter was pointing out, there could be a cooperation between the member states to say, okay, we have an issue. We have an issue of fragmentation. The Belgian market, which is a medium-sized market, okay, should not be considered a tiny market that's not available. We have these kind of fragmentation issues, so we need to see if there's coordination. Like in Canada, the coordination that Walter is mentioning is without the federal government of Canada. It's a coordination between the provinces, kind of like the member states, and the industry. It's an agreement, actually, a pact between those different parties without the federal Canadian government's involvement in that. And so you could have agreements like that. There would be a cost. But if you take the critical medicines list, at least the legacy generic versions on this is peanuts in the pharmaceutical budget, absolute peanuts. So if we have to adjust absolute peanuts, it's going to be a few more peanuts, but I don't think it's going to really break the bank here if we want to go for security of supply. But I think that's not the only area. You know, if there's an issue with a declining volume product, hard to manufacture, you know, maybe we need to work together with some member states about common packaging, about some things, which is always difficult in Europe to do. I don't know why, it's so complicated. Because probably you would prefer to have less than ideal packaging, but have the product, than having perfect packaging and not have the product. And I think, you know, we always have this discussion, but it never seems to advance. Again, an issue of coordination. It doesn't have to be with the Commission, it could be with a group of member states or something like that. But that seems to challenge. On solidarity, I'm going to challenge a little bit Gloria here. I can see right now that after COVID, the issue of solidarity is off the table. The member states are in the mood of competing over stocks because there have been a lot of stockouts, a lot of supply chain constraints. You can see the big countries, France, Germany, now Poland, all of them putting mandated stockpiling requirements. It means our members have to hold a certain amount of stock for France only, for Germany only, soon for Poland only, which means that Belgium has a problem as they sit between France and Germany, sort of. Well, that's their own problem, right? We cannot send the French stocks. And I guarantee you we cannot because our members just got a fine yesterday of 8 million euros, okay, in that kind of context. So, you know, they'll only be fined once. They won't be flexible a second time. And it's going to be the same in Germany in the next 6 months. And, you know, where's this stock going to come from when we have constrained supply chains? And we know that there has been really no thought in the context of the French stockpiling, of the German stockpiling, about what does this mean for Belgium? What does this mean for Slovakia? What does it mean for other, not even small countries, and not Malta, I'm talking about medium-sized countries here. There has been zero consideration of that because it's all about guaranteeing the supplies for them. And you know, this is a real problem because we are having supply chain challenges, and so we cannot move that stock, even though that's the most efficient solution for 9 out of 10 shortages in Europe, according to the Technopolis shortage study. So, you know, that's another area where I think the critical medicines paper led by the Belgians, it put it starkly on the table. Are we for solidarity or are we for individual member states? The choice was we are for solidarity, but we don't see that in practice.
Yeah, so, but there are many ways to deal with stockpiling, right? So maybe we get back to this if that's not too technical. And you're absolutely right. We need to remind everybody about the solidarity that we did achieve during the pandemic, okay? So that people remember that. Now, we're going to open up for. So can I introduce Hanna over here, Janga Steiner, who is watching is it like Eurovision Song Contest? Someone sitting, refereeing, seeing how people are voting. So we have questions in the chat, but as I promised, I want to invite Yannis here because. And we need to talk about manufacturing later. We need to talk about resilience, which is key, really, in the new Commission mandate and the political guidelines from the Commission President, and I think supported by the Parliament. So it's broader, right? So I want to come back to that in the second round of discussions, right? You know, where and when and how, you know, and who does what, you know, what does HERA do, what do member states do, right? But in general, what is the... how should I phrase it then? The understanding by payers that some medicines are simply too cheap. Can we have it? Oh, sorry. This was a bit off-scripted. The microphone to Yannis Natsis, ESIP.
Thank you very much. Thank you. Thank you for, it's wonderful to see Medicines for Europe coming to Gastein. So it's a pleasure to have you here and to have this conversation. What I'm missing is, okay, we say that there are bottlenecks. We agree that we need to strengthen the supply chain resilience. But my question is, do we really know where the problems are? Because Tariq said that you said that it is very hard to get this information. And Adrian, I'm looking at you. Are your companies ready to go transparent and tell us really where the problems are? Because we can claim that there are issues across the supply chain. I'm not doubting that. I'm not questioning that. But if we are to come up with flexibilization of the state aid rules, or to change our procurement rules, or to facilitate and enhance the supply resilience via costly manners, we need to have some evidence or some proof or some reassurance that in the end, at least we will tackle those shortages. Because we've seen, I'm going to get a bit cynical here, but just to trigger the conversation, whoever pays the highest price doesn't have a shortage. I'm just being provocative right now, but I'm just saying that this is something that, of course, it is important, and also on our side, and our members, the EASY members, realize that in certain cases, and we have to be very careful not having blanket statements, it might be justified indeed to review or look again at our pricing policies in order not to kill competition on the market. But we as payers signing these deals with the companies, we are the first ones who want to strengthen the competition in the sector, within pharmaceuticals, because we keep talking only about the competitiveness. So we're the first ones, we're all in favor of having a healthy and robust generics competition. But we need to have also some reassurances that, first of all, that this will treat the problem, and some guarantees that this is not going to be asking for 2, 3, 4 euros more per product, or I'm just giving a very simplistic overview. Thank you very much.
No, but thank you, Yannis. And, message received, understood. No blanket sort of price increases for everything. But it will require a bit of a technical conversation or detailed conversation with your members and your friends to actually get into the details, right? And it also requires more transparency. Looking at you, Adrian, we have had this conversation many times. I mean, if there's one single crumbling factory in China that produces all the substances for the world, and is about to be shut down, nobody wants to invest in it, then why don't we talk about that? Okay, maybe we need to build one in Europe, but we'll come back to that. Okay, so I think, but are your members ready, Yannis? You don't have to answer, right? They are. I know they're ready. They're ready to talk. Yeah.
Just to say that within EASY, we did an internal survey where we mapped the responses to the big crisis we had 2 years ago. You remember, 2 winters ago. So we are coordinating, and we have also one of our members is in the room here. So we are already acting on the problem, and of course Gloria knows that this is already happening. And adjusting, by the way.
No, so we need to break down, essentially. This is one of the big interim conclusions, is that you have to disaggregate the problem. It's not one solution fix everything. You want to come in, Walter, quickly? I want to let the other in the audience come in.
I agree with you. So I think I also mentioned it at the beginning. You cannot just apply, let's say, a tiered pricing system without transparency. So transparency, and what transparency? Well, transparency that shows, for example, the supply chain costs. So that says, like, if you want to have a system that is up to this service level, then this would be the cost. So I also thinking, like, and I'm thinking loud because I haven't studied this in detail, but I mean, in innovative medicines, we have the concept of market entry agreements, as you know. So you might think in terms of such a contract. So where you basically say, like, pricing works following this system across the union because we don't want to have the thing you pointed out that one country says, like, I pay the highest price, so you come to me. That's not really very solidarity. so that's not following solidarity. But also saying, like, well, on these points in the supply chain, I want to see, how you organize, and measure it up.
Yeah.
I mean, for the moment, as a researcher, if I want to look into reasons for shortages, then I have to go to the EMA, as you may know, and there they only report issues that are cross-country. So there are no country-specific data on this. Then I would have to come to you for each country, so which is bad.
Well, so maybe I didn't say I work for IQVIA, so I work for IQVIA, and we actually have a service for governments, and also we share with the institutions in Brussels and the Commission.
We should institutionalize this, Richard.
Where we monitor this, okay? And we don't make it public because we don't want the press to pick this up, because then people start to stock up and trade and stuff, So anyhow, but there's still room for improvement on transparency in supply chain. My dream is that we would be able to somehow to see the production plans even of companies and stock levels way back, in time, So if now we have like maybe a month's warning, when things go out of stock in this country, we can warn another country saying this is going to happen. But what if we had a much longer horizon? But that requires an understanding between the various parts of the industry, and also maybe endorsement by competition authorities and others, that we actually start sharing information. Now, we're going to come back to the whole issue of resilience, which has the component of stockpiling in various forms, and onshoring or reshoring production back to Europe. There's a lot of appetite for that. I mean, just again, read these mission letters, and it's all over the place about Europe and bringing things back and being less dependent on other people. But I want to open up for, first, if there's anybody else in the audience. I'm not going to throw out another ball. I've done one already. You can come back later. I think we have time for more questions. How about the online, Hannah? How is it looking? Do we have any interesting questions, or is it buzzing out there?
Yes, it's interesting because a lot of the issues that you just mentioned that you want to tackle in the next section are coming up here, for example. And the audience really wants to delve into those specifics about what a critical medicine is, what the main risk factors are, and how to address them. Looking into things, as you mentioned, like reshoring, stockpiling, procurement, and the kind of diversification of supply chains, the policies and tools that we have used in the past, and the kind of things that we could come up with in the future if there are completely novel mechanisms we could look at. So the debate is definitely
very
going on online, for sure.
It's a very outspoken language there by Anonymous, on pharma will hate this and so on, so probably correct, but fine. So let's turn to this dimension of European resilience. So there's one thing that we learned during the pandemic again, that certain medicines probably should be in some central stock somewhere, okay? Propofol and stuff used in emergency rooms and so on. That's one thing. Then we look at regular medicines, that everyday medicines, asthma medicines and cholesterol-lowering drugs and so on, where we have vulnerabilities because of supply chains and fluctuations in price and tendering and all that. And of course, one model, if I turn to the concept of stockpiling, is of course one model which we have in some countries. Finland has it, and I live in Switzerland and we have it, is this concept of rotating stock. There's always 3 to 6 months stock available for everything. Doesn't cost that much actually. Maybe we need to build a few more buildings to store things in, but still, it's like 1 to 2% cost for having more rotating stock, which should be done for many things, not just the absolute critical ones. So there's also the whole idea that you reserve capacity for manufacturing. Maybe that's more for countermeasures. I don't know, Tarek, I'm looking at you. You should come in and reflect on this. I mean, you have a lot of thinking going on, I know, about revenue guarantees and reserving capacity and having spare capacity, what we call ever warm, they call it, ever warm. You've heard the term, ever warm factories. That's sort of ready to go if something happens. So who wants to go first on this issue of? I want to come back to incentives for bringing manufacturing back, which is another dimension of this. But just on this stockpiling and stock management and even transparency of stock, Adrian, what are your thoughts on this?
Yeah, so I think just on the transparency point in general, there are different pieces, but I would actually agree with Yannis, agree with Walter. If the expectation is that we're going to adapt, I would say, the pricing models for generic medicines, which, although they're only 20% of the cost, they're still 70% of the volume, okay, of the medicines. Maybe the critical is much smaller component of that. But if we're going to change any major chunk of this, there has to be a back and forth. So there has to be a commitment from our industry or other participants in the market then to improve things. So on the pricing transparency side, I think you're looking at a model that could make this more transparent so it's in some way fair for both sides. On the supply chain side, we would also expect, and that's where you see meat criteria, which could be applied in procurement, but it could also be applied in pricing rules. This is where you could say, okay, do you have a certain number of guarantees in your supply chain that you have redundancy, so that, I don't know, you have certain inventories so that you could rapidly reply? Or resilience, meaning you can adapt your supply chain very, very quickly to, say, speed up production, which usually requires workers, for example, to be able to do that, very, very specialized workers. So, you know, then the extra payment is for extra security, essentially. That's how I see the kind of arrangement. And for that, there has to be very clear rules and a clear way of evaluating, yes, this company or that company has made that additional investment, is making that additional effort, and therefore they get the additional reward. No, this other one is clearly not, so they do not get the reward, or maybe they don't get to participate anymore in the market. And I think this is missing from the generic market in general, also for the critical medicines in Europe. And I think these things are not that difficult. We have criteria on the supply chain side that we think could work this way. And you know, there's a certain transparency. When it comes to stockpiling and this kind of thing, we need to be, I think, very cautious with the national stockpiling measures being put in place, because these are typically very rigid. Typically they are not paid for, which means it has to be absorbed by the manufacturer, which is easier if you have a factory in that country because you have a warehouse. Otherwise, you have to pay a wholesaler to hold your stock for you, so you pay a fee. Okay? And for these very ultra-low-cost generics, that may be enough of a decision to say, okay, I'm leaving this market. Okay, so I think you could see even more consolidation of this if you don't see this. I think at European level, if there would be some kind of coordination between the member states, we would have to have a very deep technical understanding of how we do that, because obviously we package differently for each member state. Sometimes even we have different national licenses for some of these products. So how we would do that, at what level, I think would have to be a very complex discussion.
So it all sounds very technical, but I guess you guys knew that when you came here, right? That this would not be a simple solution.
It's possible.
No, but you're absolutely right. But Gloria, what's the willingness among member states? So okay, we have the payers represented here as well, but you know, member states and this recognition that if we were to move to a system where we have some, you know, rotating stock all the time for everything, is there an acceptance or realization, what Adrian's saying, that will cost something? And the prices are already so low for these tendered medicines. Is there an understanding that maybe the prices will have to go up a little bit?
Well, first of all, you need to go to the system where you would have a stock, right? And maybe I want to jump in on this question of solidarity again, because I don't know whether to agree or disagree with you. In a sense, because we are also very disappointed with the German and the French measures, and we know that they affect our market. Then again, I would not per se say that this is because they don't want to show solidarity with Europe, but it's because they have a very specific experience where they have lacked medicines and their patients were very, very worried. And I think on a human level, we need to understand this. I also think that maybe this also is caused by the just-in-time deliveries, by systems that are not robust against demand spikes and stuff. And I think that's the other side of the coin, that sometimes like the supply is calculated like with very, very thin margins. And certainly on the Belgian markets, we know that a lot of companies implement contingency measures to avoid parallel traders exporting products. So what they do is they put just enough on the Belgian market, but then the moment you have a spike in demand or whatever, you get the shortage, you get the disruption. And so I think we need to recognize that some member states act with stock measures, but also because of the way the system is. Now, that being said, I do think that the negative spillover effects are too great and that we need a European system. And there I would agree. And in the meantime, until we have such a European system, I think stockpiling measures should at least not stand in the way of the solidarity mechanism, meaning that some member states also have export restrictions on the stock, and I think that's really, really wrong. If you have a stock, at least it should be able to be shared with the member states, with other member states in case of a disruption.
No, we can find a bunker in Brussels where we hide all the drugs, so they don't have them, because I think that's an important element. But I must ask you though, Gloria, or comment that the governments have created these these systems which drove prices down. I mean, I've been long enough in this industry to remember when we paid a lot of money for off-patent medicines, And then the financial crisis, not the least, forced everybody to look for savings. And there are different models, Sweden has one, Denmark another one, they all have different models. And it's deliberate by governments. And in fact, Walter, one of your fellow economists corrected me once when I said this is a market failure. I said, no, it's not a market failure. If there was a market, it would work. It's a public policy failure. Because you've implemented measures, measures that sort of distort the market. Yeah. Again, why this whole discussion has to involve everybody.
But I mean, the measures of impacting the price and transparency of price, that's the interface that you have with industry. But next to that, it's an and basically. So I think at a policy level, at a payer level, there too, you need to straighten out, let's say, with your colleagues, the solidarity mechanism. What I hope is that when we install this new way of working with industry, that this gets ironed out a little bit, because we will have a more sustainable system. That's what I hope.
Yeah.
Maybe if I can...
Yeah. Yes, of course.
Yeah, because we did launch under the Belgian presidency a pilot project for a price fork of antibiotics. So we do know that the system went too far. It was implemented in the beginning of the 2000s to drive down the prices of blockbusters, so it's coming from somewhere, but then austerity measure after austerity measure, and I mean, it went completely, it went completely the wrong way. So there is this realization. The question is, okay, we are in the situation now, where we are now, how do we build up again? And there, systems like a European price fork, I think European minimum standards, and I'm really thinking of legal minimum standards for implementing meat criteria in public procurement. The continuous dialogue and also the transparency that is required for working together. So it's not, I challenge a little bit on the pricing sometimes, because it seems like if we pay €2 extra per package, then suddenly all our problems will be solved, and I don't think so. But then again, that is not to say that we don't realize that something needs to change, but it better happens in a European way.
No, and you're kind of saying the same thing as Jan is saying. There's an openness to discuss, but we can't be some blanket formula, It's a good point, Walter.
It's good that Gloria is talking not only about this price that you say like is going to be through the roof or something, but I mean about the price fork. And this price fork, there should be like a minimum price that you pay, given a certain organization of your supply chain. Yeah. And that you say, if you foresee these and these and these points, then we can get to this minimum price that we then have to abide to as a system across Europe. And here again, the punishment is, if you don't, you will have supply chain shortages.
But the industry, as you know, has an allergy, or even more than an allergy, against cost-plus discussions, as you know. I mean, it's about value. But here, we have a special situation here. Anka, we need your help, because this gets very technical, okay?
I'm not sure if I'm going to help, but yes, please.
Yes, so, how do we make sure that we not only bring along that constituency, Gloria's friends in the member states, with the payers and everybody, how do we make sure that we contextualize this with citizens? Why don't I get my medicine? Okay, I can start talking, and then they get lost after, because we make it very technical. Well, Anka, do you have any thoughts on that?
Well, I mean, I guess the simple answer would be transparency of prices. That'd be wonderful. It's not something that's a new idea or anything. Transparency of prices, of stocks, and of the mitigation measures, the risk mitigation measures. It would be the first thought that comes into my mind. And transparency is a prerequisite for trust as well. So, or at least for discussions that maybe lead to trust. I would also throw another little grenade into the discussion. If we're talking about, solidarity, and we're talking about tenders and the role, and it's something that we support, tender criteria that also include security of supply. I mean, that goes into the meat umbrella. I would also ask, if we're talking about these things, we should consider joint procurement of critical medicines as a very important public health tool to ensure supply. As I said, grenade. And I don't think it can just be discarded just because it's an inconvenient conversation to have. It's something that we occasionally bring back into the Critical Medicines Alliance. So there's that, but there's another comment that I would make. I think, look, two things to be said about incentives for reshoring of production. And there are concerns, and I'm sorry I'm not bringing solutions, but it's something that we are mindful of. The first one is you will never have a perfect production supply chain based in Europe because your raw materials are often not coming from Europe. You cannot achieve that without some level of international cooperation, which is also covered in the Critical Medicines Alliance. The second thing that I would say is, it's very nice. Thank you, Yannis, for being willing to pay a little bit more, if I understand correctly, to keep medicines available, willing to discuss the possibility of discussing paying a bit more, sorry. For us, it's also important that these incentives are not passed on to patients in the form of co-pays, and that patients are not penalized for these either, economically speaking. So that is the second concern that I wanted to say. So there, now that I blew up the conversation, I'll shut up.
No. The grenade, usually I'm the one throwing that grenade on joint procurement. But Tariq, I want to turn to you in a second, but I want to first also mention, I said this yesterday at another session, which most people are not aware of, which shows the leadership of the European Union and the Commission on mpox. We have vaccines in Europe, but why do we have them? Well, first of all, they're actually paid by the US government in their programs, right? But the Commission swooped in and said, we buy everything you have from that company, and then donated them to member states, because member states couldn't make up their mind on if they needed this. Is this important? How many doses do we want? And is this cost effective? Have we done HTA? I'm not making this up. I was right in the middle of it, okay? The Commission stepped in, okay? So of course that takes us, towards the end now. We need to have a reflection on, what's best done at the EU level. I mean, we can give here our 20 billion, 25, and you do all this for us. But that's not going to work, right? No. I put you on the spot.
I'm not sure.
Here.
I don't know yet. Maybe. I don't know. But this is what the Alliance is doing.
No,
just on the mpox, thanks for acknowledging this. Thanks to Belgium as well. They also give a kick at the beginning to start this process. And in a record time, in 4 days, we were able to negotiate with the company, find get 20 million euros from other Commission programs and ship the vaccine. So it was a bit of a busy time in August, and thanks, Richard, for recognizing this. We've been touching upon many things. Stockpiling, stockpiling is being discussed as part of the alliance, but is also a sensitive topic, hot topic discussed as part of the pharma legislation review. When it comes to medicine, HERA involved in stockpiling. When it comes to medical countermeasure, and we do have mechanism for that. We do stock a few medicine together with other DG services, DG ECHO, and we do have that mechanism in place. But again, what are we talking? It's not what are we talking about. I think stockpiling has many facets or many faces. What do we stockpile? API, starting material, finished product, where, who, how's the governance? I think, and these are things that will be discussed, that have to be discussed, touched upon in the alliance, but I'm not sure the alliance will be the right forum to make those final decisions. When it comes to procurement, Anka, you mentioned that procurement moving away from the low-cost medicines, like using this as the main criteria, and I think this is brought forward in the discussion. in the award criteria, how do you reward those manufacturers that will ensure that security of supply, that have invested in production line in the EU, and that adhere to greening criteria, to social norms that apply to the EU, and so on. So this is a discussion that is ongoing. Also to mention, and rightly said by others, that we talk a lot about reshoring, onshoring, bringing back production in the EU. Yes, there is a will to have some sort of industrial base in the EU. I mean, re-industrialize part of the medicines production, critical medicines production in the EU. But this is not a goal, and this is, we have also, as part of the alliance, working groups and the reflection on working with those third countries. We do know that part of the starting materials will probably never be produced in the EU. There's not that industry anymore. We will not be able to adhere to the environmental norms. So, working with non-EU countries remain, of course, an objective. And here it's not about full strategic autonomy of the EU that is being put on the agenda, not at all.
Right. But if you read the Draghi report, which is referenced all the time by the Commission President and everybody else, it seems to be a strategy to boost the sector. Not only manufacturing is one part, but also exploiting data and European health data space and everything else. So I think there's an ambition there as well, So we have to overlay the critical medicines agenda with that agenda of Europe's competitiveness. Let's be frank about it here. I want to come to you, Adrian, in a second or a minute on realism. Think about this, realism of getting things back to Europe. But I want to open up for people in the audience if someone has a question or a comment. There's a hand there. Yannis again, but Yes?
I'm Tamara Harvey. I'm a professor of European Union health law. And thank you for the very rich discussion that I've learned a lot from. I'm hearing two different narratives in terms of the needed legal structures here. So there's one narrative that's about regulation, and that includes things like transparency obligations and so on. And there's another narrative that's about contract, regulated contract for sure, but that includes the things like the public procurement rules and so on. And I'm wondering, which is the right track for the EU here? Because they're very, very different in terms of both competences and which other parts of the EU policy and law machine have to be engaged with in order to achieve the end goal.
Maybe we pull up that last slide of Paul, by the way, on that, because that's one of the that's our final sort of question. We can come back to no, but you're up to the right. Where's the right level for dealing with this? Because it probably isn't one solution for everything, right? Can we bring up this last slide?
I don't mean level. I mean type of legal structure. So you could have a contract type of legal structure at a European or a European Union or even bigger Europe level. So it's not just about this.
No. It's a level thing that is also a modality thing.
Yes, exactly.
No, excellent point. Maybe we can get up. Okay, so we're not going to stop. We have a few more minutes, but still, I want to do this one. Where do you think the key solution for improving access to critical medicines lies? EU-level actions, such as this act we're talking about, including to improve the competitiveness, national actions for supply security, or a combination of actions at both EU and national levels. Maybe, again, a leading option, I don't know. Please, if we can have your votes here. Yeah. Again, we are nudging you in the right direction. Yes, so to be reflected in the future legislative legal work, with the act and everything, where do we put what and so on, right? So, but spot on with your question, even if we can't answer it today. Or Gloria, do you want to say something very briefly on that? No?
Yes, thank you. I think, so first of all, many of the transparency measures are actually already in the pharmaceutical legislation. But to me, transparency is more also about culture, really. And I'm always inspired by the US, I have to admit that. When you go to the US, BARDA has a very open relationship with suppliers, and I think to a certain extent that's what we need in the EU, a more open relationship with suppliers and a more open manner of working together to find solutions. I think that's really important. On the public procurement and the contract type, I would take the inspiration of the other acts, the CHIPS Act, we have one on electric vehicles and whatever, where typically these acts are a type of toolbox. And if you think like for the public procurement, for instance, we have a legislation in the Net Zero Industries Act where for electric buses, I think, or no, it's in the Clean Vehicles Directive, sorry, this is very EU speak, where we have for electric buses minimum procurement standards for procurers. So imagine that you have a city council wanting to procure electric buses. They would need to take into account where the battery is produced, because we want part of the battery supply chains in Europe. And so you need to create a market there. And you don't want the European producers to compete on equal footing with the Chinese ones. And so we could think of something similar for certain critical medicines. I think that would be possible. And I think we need to make it legally binding. I would be a little bit strict on this because we have so many different types of procurers in the EU, like hospitals and whatever. You just need to make it legally binding.
Yeah, and many of the schemes are not actually procurement in a legal sense. They're procurement-like. And the Commission tried, I'm old, lots of grey hair. There was an attempt once to revise the Transparency Directive on all this, but member states didn't want to. So anyhow, now teasing you a bit, Gloria.
On this, what you were asking about the different contracts. So many member states have a contract with the pharmaceutical industry today, which is a cost containment contract. I believe, for example, Belgium has a cap with a certain percentage growth above 4 billion euros or something like this, and then there's an agreement. In France, they have this as well. So many countries have this kind of agreement, but it's mainly about somehow capping the pharmaceutical budget. In the context of that kind of negotiation, you could have a security of supply component in there, in that kind of discussion. Yeah, because you apply a clawback in Belgium, so you do have that. The clawback is set according to this agreement. It's a cost.
So I was teasing you a bit, Gloria, there, but you're absolutely right, and Adrian's correct, absolutely correct that there are ways. In many European countries like yours, we do indeed have these overall framework agreements, where people pay back, clawback. Record is Greece with 57% clawback every year, I understand. Sorry, Yannis, I picked on Greece there. You get 30 seconds now, just because you're my friend.
Tarek, how confident are you that you have the full picture and you have good data based on the supply chain and the bottlenecks, and how much better equipped you are compared to a few years ago with the structured dialogue? So if you can tell us, because that will trigger and that will feed into, as you said, the act. So we need to have a solid basis and to know what we're talking about. Thank you.
I wish you would have asked me that question in 2 minutes, so it's off the record. No kidding. But I mean, yeah, having access to data is key. I mean, we did that pilot exercise. We had some data, not the full data, to make a comprehensive assessment. Okay? I mean, we did link with manufacturers, with member states. There was not a full availability of data that we would have required for a full assessment. As part of the proposed action that we could foresee in an act is the need to have access to data, to call for transparency, have more data, really define the data we need to properly assess vulnerabilities in supply chain, yeah. But for now, there was limited access, yeah.
Yeah, right, so we're actually out of time almost in 2 seconds. Now, we do a very quick round here of final reflections. Anka.
Just one sentence. for me, what's important is that the Critical Medicines Act in the future and the work on critical medicines, it doesn't just become an industrial strategy, but also a public health tool.
Very excellent point.
It's all about collaboration instead of being competitive and being against each other, and everyone does its own thing. And I'm happy to hear that this is moving. Let's move this a bit faster, maybe.
To me, it's about supporting the industry on the one hand, and then creating the market for the medicines that we support on the other hand, all in a framework of greater transparency. That's how I see it.
A few things, sorry. I mean, I think we have to set expectations in what we're going to achieve as well. I mean, it's not going to solve in one day. As I said, we're looking at mid to long-term solution. For us in the alliance, I mean, one of the key aspects is how to mobilize the investment, how to incentivize how to incentivize and reward the investment that can be done to ensure security of supply in the EU. And hence we are building a toolbox and looking at all the possible funding mechanism, funding opportunity that exist to reward those investments that will help ensure security of supply for critical medicine.
Adrian, so this is, as Anka said, this is a two-pronged approach, isn't it? It's both about patients, but it's also about Europe and industrial strategy, or?
No, absolutely. We didn't have the chance to discuss it, but I absolutely believe that the Critical Medicines Alliance and ACT should have a strong industrial component, because you benefit from having a strong manufacturing ecosystem in Europe. We were also contributing to vaccine production in some ways, fill and finish and this kind of thing. So having this in Europe is a benefit when you really need it. But the other thing I think that we've discussed here, this was actually a fantastic and open discussion. I think really thanks to the discussion of the Critical Medicines Alliance and the paper, calling for a Critical Medicines Act and all of this, we're able to put these issues onto the table and discuss some of the problems. I actually think this won't be a huge cost, and I think it will most likely not fall on the patients, because a lot of these are hospital medicines in any case. But I think what it will do is it will change eventually the pharmaceutical market in Europe for these critical medicines towards buying from the best in terms of redundance, resilience, supply chain suppliers, versus the current model, which is from the absolute lowest price, which may or may not be the best in terms of redundance or resilience. But if we change the market signals like that, the market will react. And I don't know which company will be the winner from that amongst my members, or which companies will be the winners, but I'm sure we would benefit from this, because the cost of shortages, even temporary stockouts and things like this, is actually huge, not just for manufacturers who get fines, but for pharmacists, for doctors, for patients who are confronted with either delays or other complications. This also has a huge cost. So I think this will actually be cost effective, and it will just change the orientation of the market for these critical medicines.
Yes, and indeed, we didn't have time to really go into the global dimensions today. We touched upon it only. But we do see signs, back to the comment you made, Anka, we see signs that, at least for new investments, the pharma industry is moving things back to Europe and North America. The new weight loss agents, they're entirely made in Europe and North America. Nothing's coming from India or China. So you don't always need government interventions, Walter. You would like me saying that, okay? Sometimes markets do work, okay? So the industry is not stupid. They realize that maybe it's better to do it here. It's safer, it's securer, okay? Of course, we will continue to invest. We continue to invest in China and India for those markets. But for Europe and North America, I think. But that doesn't mean that all your members, Adrian, can close down what they have and move it back, right? That's the thing we didn't have time to talk about, but we'll do it over a drink at this lovely event that we're going to have later in that direction somewhere, right, in the evening. Now, thank you all, you online. We weren't able to capture everything, but maybe there'll be some follow-up conversations. Thank you all to you here in the valley, as we say. Don't forget to fill out the evaluation form. And I'll see you later, all dressed up as, what should we look like? Beachwear? What was it? Yeah, there was some dress code for this evening. So anyhow, looking forward to see you then. Thank you all.